Our next presenter is a special guest. We have the pleasure of introducing Dr. Hossein Nazari. Dr. Nazari is a board-certified ophthalmologist and vitreoretinal surgeon with Minnesota Retina Associates. He's got over 2 decades of clinical and research experience. He specializes in the diagnosis and treatment of complex retina disorders, including diabetic retinopathy, age-related macular degeneration, retinal detachments, and inherited retina diseases. His talk this afternoon is titled Peripheral Perils, a comprehensive guide to peripheral retinal pathologies. Welcome, Dr. Nazari.
Thank you so much.
You've got it.
All right. Sure. Thank you so much. All right. Good afternoon, everyone. Thank you, Anna, for the introduction. Hossein Nazari here. I'm going to go ahead and start my presentation. A lot of topics are going to be covered in the next 30 minutes or so. This is by no means a comprehensive guide, though. Feel free to, yes, this is a scary picture from Optos, shows all the pathologies that can happen and will happen. At some point in our life, we are going to see these in our patients, hopefully, not in ourselves. Anyway, so a lot of topics are going to be covered. Feel free to interrupt me if you have any questions, or take a note and save for the end of the presentation. So retina periphery is where most of the actions happen, at least in my world. So our goal is to sharpen our referral reflex, so a knee-jerk, reaction that we know that something's wrong. So a lot of pathologies you're going to see, we are all familiar with, and so these are just probably mostly a review, but here and there you'll find less common conditions that we practice for years, but eventually, as someday, shows up at our door. So I'm going to talk about peripheral retina tears, degenerations, lattice, detachment, and that sort of diseases. And then mass lesions and tumors, melanoma, cherpy, nevus, that type of pathologies, and eventually part of the uveitis and inflammatory conditions that show up in periphery mostly, rather than anterior segment or posterior pole of the eye. So first, let's look at retina peripheral degenerative changes, retina breaks and holes, and similar conditions. PVD, there's no need for us to talk, definition, and these are you're all familiar with. I think these numbers, I memorize them. I use them in every day with my patients. 10% of people by age 50 have a PVD. By age 70%, almost 70% get PVD. And out of these PVD patients, acute symptomatic PVD, when they come to us, 20% can have a retina break or a retina pathology. If they have a vitreous hemorrhage, 50%. So if a patient comes with PVD, acute floaters, a little bit of flashes that resolve, but now we see vitreous cells, then there's a good chance that they have a retina tear or peripheral pathology. We want to dilate, depress, take a look more carefully. And if a break is not found, so this is almost like a preferred practice, that they need to be re-examined, tortured again with all these depressed examination in 2 to 4 weeks. A good chance, 50%, they have something going on. What type of breaks can happen? So horseshoe tears, which is the most quintessential or typical type of retina pathology, retina breaks, but also smaller holes, wider holes in the posterior aspect or border of lattice, giant retina tears, operculated holes, dialysis and whatnot. And of course, macular hole, which is a totally different pathology, right? So it's not associated with PVD, or it's categorized in a different different class of retinal diseases. So the location is important where patient has their retina breaks. So young people can have asymptomatic breaks, those who are high myopic, and they may not present to us, especially if they have an inferior break or hole. So they come to us with a shallow detachment, with a small one or a couple of tears in inferior retina, and they live their life, for months, sometimes years with those holes. But eventually, these detachments and these tears are gonna spread and progress, and it's our job to detect them, and guide them to proper treatment. Whether there is subretinal fluid or not is gonna, tell us how urgently we have to deal with this patient. Pigmentation, around the break, so could be a break could be an incidental finding, and if you see pigmentations around the break, probably we don't need to jump on action immediately. So showing that this has been there for a long time, enough that RP has started to proliferate around the tear and close the tear. Whether there's traction around the tear or on the tear, especially in this is the case with horseshoe tears or not, and then whether there is a hemorrhage or not. So we talked about the hemorrhage. So treatment, we almost always nowadays we do laser treatment in 2 to 3 almost confluent rows around the tear. And cryo is also technically one of the treatments, but we nowadays we rarely do it unless I have a pneumatic retinopexy and I cannot do laser for that patient, so I bring cryotherapy to apply cryo spots around the tears. So going back to horseshoe tears, so 55% progress to RD. So again, not 100% of them, but a good proportion of them can progress to RD. And even if we treat them, 5% of these patients with acute symptomatic horseshoe tears may progress to RD. Maybe we missed the tear, or just traction was too so much that opened the tear before our scars build up. Round holes are more benign, and they don't progress to the detachments or don't progress as quickly. For example, in kids, we talked about the inferior breaks and inferior holes that can progress to detachment, but usually in a chronic, more quiet fashion. And then lattice is also a common pathology that we see in the periphery. I have a few pictures to show you, and so we don't automatically treat them unless there is a risk factor, or unless there is a tear associated or traction associated with the patient, with the lattice. So this is a patient who presented in 2019 before I started my practice. And at that time, she was a high school student. Now you see that things look okay, but if we look more carefully and if we can darken the room, that'll be great. AV people in the back. But so we see that there were a couple of atrophic holes down here. She's a little bit high myopic, not a little bit, -7, -8. And then left eye also had some atrophic holes. And then in retrospect, I looked at her autofluorescence from the same time. There was a little bit of hyperautofluorescence around those holes. Probably there was a little bit of subretinal fluid at that time. So, but she was followed, and she came back to us with this retinal detachment. I'm going to show with my cursor here. So with this retinal detachment that is progressing to the macula. So, and this is my third day joining my faculty practice at the university. So I'm a little bit nervous, but I've dealt with these patients before. So I took her to OR and placed on a scleral buckle. Now this is 1 year after. She's doing great. So just the point is that we want to take a look at these peripheral pathologies in kids, high myopic patients, those who have some risk factors. We need to be more careful with our follow-ups, closer follow-ups, referrals, and whatnot. So giant retina tears, so we are going through different retina tears and holes in the periphery. Giant retina tear, that is defined as a retina tear that extends more than 90 degrees or 3 clock hours. So this is a patient I saw at the university, but then we didn't have OR. I operated in a MEC OR in Bloomington. So he is a super nice gentleman, came with horseshoe tear, giant retina tear and detachment. The other is fine. So I took him immediately. Luckily, we had access to OR in Bloomington. Did vitrectomy, good laser, and tamponade, and he's fine. He comes for follow-up, week 1, month 1. Month 3, now this is the left eye, horseshoe tear. It's a giant retina tear again in this eye. Again, right eye is good. So the left eye also underwent surgery. So these are usually giant retina tears, either with trauma or there is a predisposing condition, high myopic, or just some connective tissue problem that when retina tears, it almost unzips, 3, 4, even longer clock hours of tears. So retinal dialysis and avulsion of vitreous space, these are patients usually post-trauma. It's really hard to see unless we really push through the vitreous space with scleral depression, but dialysis is when retina separates from ora serrata, from pars plana, and then fluid goes under. Usually happens after trauma, as I said, in younger individuals, but just because of being young with a thick jelly vitreous, they don't present acutely. So there's a tamponade of vitreous there, and they may come later with their retina detachment, unless trauma is so bad or dialysis is so bad that they present acutely. Avulsion of vitreous base is when vitreous base separates from retina. There is no retina detachment directly, but this is almost a pathognomonic sign of blunt trauma to the eye. So this is a 4-year-old girl who was hit by a wooden stick playing in yard. Super nice little kid, nice family. Doesn't have any vision issue. They just brought to get her eyes checked. No pain, no light sensitivity. She's able to sit comfortable, watch TV. Anterior segment examination is fine, but our resident, very astute, resident, looked carefully and saw that there is a retina whitening towards the periphery, probably a commotio retina. And then, so this is how the retina is in posterior pole. So I took her to OR. So these are pictures from RetCam. So posterior pole is good, but then in the periphery, when you go to the periphery, you see the retina whitening. And if you really go to the periphery with depression, you see that retina is detaching. So with the scleral depression, it's hard to see within this opto RetCam picture, but there was a dialysis, but then it was so large that the progress to retina detachment almost acutely. So I took her to OR, so did a scleral buckle and a good laser with indirect around it, a cryo laser around it, and she's doing fine. This is just a few days after, eye swollen, painful, didn't open the eye, but then this is an EUA 2 weeks after surgery, and she had good vision, central vision, and maintained good. Now that we are in the topic of traumas in little kids, so look at this 7-year-old boy who was playing and suddenly felt a sharp pain in the eye, and he has a foreign body in the eye. So again, a peripheral foreign body. Front part of the eye looked really benign and good. So I see that foreign body in the periphery. Of course, CT scan also showed it. However, there was those whitish infiltrates around the eye. So I put the Helon in the posterior pole just to protect macula if when I remove. So this is a magnet that helps me pull the foreign body out. So this is not huge, but huge for the eye. And then you see that, retina is starting to become, infected retinitis. There's a whitening beyond the impact site of the foreign body. I put good laser, and then thinking about the infection, I put oil in the eye. This is after a few months, and then after 12 months. So he father called a few weeks ago, said that, I'm so grateful, thankful. My daughter has now, my boy has 2015 vision. Grandparents are millionaires, and I'm going to become a millionaire and donate money to the university. I'm hoping that he becomes millionaire. So, okay. So anyway, but look, this is an endophthalmitis and retina, and I have more pictures. So these are pictures from the day 1 and day 2. It's already developing abscess, even outside the impact site. So oil is in the eye, but this is day 3 or maybe day 7 or whatever. But I injected antibiotic multiple times, and it's getting better. And then you saw 1-year follow-ups. So let's recap lesions that predispose to RD and those that do not predispose to RD, because we see so many color changes, lesions or abnormal features in the periphery, right? So not all of those predispose to RD. One that predisposes to RD is lattice degeneration. This is obvious, all of us know. In 10% of population, we can see myopes have more lattice degeneration. But out of those who have RD, 20 to 30% of RDs, rheumatogenic RDs, have some sort of lattice and tear associated with that. They can have atrophic holes, or they can have vitreous traction, PVD, and horseshoe tear next to the lattice. Other predisposing lesions are tuft lesions or meridional folds. Again, these are far periphery, a lot of pushing and pulling on the eye for us to see, but nevertheless, there are RDs that originate from these tufts. So if you see a RD and you depress and you don't see a tear, there's a good chance that some chance that they are developing from these harder to see pathologies in the periphery. So what do we do for these lesions or any lesion? So if patient has symptoms, of course, they need treatment. They need referral, photopsias, new increased floaters, and of course, curtain sign and peripheral vision loss that is probably more advanced in the course of the disease. Other risk factors, myopia, any myopia, even low myopia, 1 to 3. Could be a risk factor, but especially high myopia is a risk factor for retinal detachment associated with the PVDs and traumas. So RD in the fellow eye, 10 to 40% of people with RD in one eye may develop RD in the other eye, and being pseudophakic is also a risk factor. So those post-cataract surgery patients, and also if they have family history of retinal detachment. So those lesions that do not predispose for RD. So it's obvious cobblestone degeneration. We see very common inferior retina, temporal retina. We see these patches of sharp demarcation, a little bit of atrophic changes, a little bit of hyperpigmented changes, but they are really, most of them are like cobblestones, really. And then cherpies, these pigmented lesions, we look at those a little bit more in later slides. And then cystoid or peripheral cystoid degenerations that, when we depress, we see something going on. There are some, especially with 20 diopter, we have a bit higher magnification. We see that there are some changes, reticular or cystoid degeneration. However, they do not predispose for retinal detachment. And of course, white with pressure, white without pressure, these could be confusing, but they are seen in younger patients. Like this patient, and we have all seen in our patients, right? These white without pressure, white with pressure. They show some sort of vitreous, more stronger adhesion, or maybe a little bit of diffuser traction on peripheral vitreous, but overall they don't predispose for a break or other more dangerous pathologies. So now, a fun fact, again, some of you may know. Why is that these pathologies are more common in temporal side? So it goes back to embryology period and then eye development. So eye temporal retina extends further away from optic nerve than nasal retina, right? So by the time, age 1 or 2 weeks after, delivery, when nasal retina is completely vascularized, still temporal retina may not be as vascularized as the nasal retina. So overall, we see more degenerative ischemic lesions, degenerative lesions in temporal retina. So if a patient has a shorter attention span, is photophobic, it just doesn't cooperate with our examination. Better to see their temporal retina than nasal retina if we have an option. So just don't miss the opportunity to look at the temporal retina if we cannot look at everywhere else. All right, so other pathologies. So retinoschisis also could look scary. So these are dome-shaped, very elevated, usually retina separations in the periphery we see. But these are also common, again, more temporal, infratemporal, could be bilateral, but these are also, very often, they don't progress to retina detachment unless there is a hole in inner, so this picture is cut out, I'm sorry, but it shows that there is layer of retina preserved in the other side. So the classic definition of retinoschisis, separation between retinal layers. But then if they could have often other holes like this patient, but unless they have inner wall holes, they're not going to progress to retina detachment. So these are also could be very questionable, could be suspicious. Again, if you're confident, it's totally fine to follow them. But if you're not, I think these are the cases that probably need to be seen more carefully with the longer longitudinal follow-ups. So so these are classic in our teachings and for our boards. So I always tell our residents that there is going to be one question from this slide, no matter what, in their boards, and that is true. So how can we differentiate retinoschisis from detachment? And again, if we think about the histology or pathology of detachment and schisis, it's easy to answer all these questions. How is the scotoma? In retina detachment, scotoma is going to be relative, right? Because even though retina is detached, but then the connection between photoreceptors, bipolars, ganglion cells, and optic nerve is not disconnected. So the connection is there. So if we shine a bright light, they see LP light or they see that light. But then schisis, total disconnect between photoreceptor and inner retinal ganglion cells. So they have absolute scotoma. And then, of course, they don't have vitreous cells. Detachment has vitreous cells. Schisis is usually dome-shaped, smooth surface, but the detachments are corrugated, irregular. So if we apply laser, of course, there's not going to be any optic with retinal detachment, but then since there is this outer layer with the schisis, we are going to see optic of laser and more detailed features of retinal detachment and schisis. I don't want to go through all those. So I think we talked about these. So these are AAO's, American Academy of Ophthalmology Preferred Practice Pattern. So if there is a break and whole asymptomatic, they usually don't need treatment. So we don't need to necessarily refer them for treatment, even though there is a smaller chance for progression to RD. But then what if this patient is at the verge of losing insurance? What if they're going to travel? What if they're going to come up with just family reasons not to come for follow-ups, right? So probably even though it is preferred practice pattern, but I have a low bar to treat them, even though they appear reliable and to come. Life happens, right? So lattice we don't need to treat, of course, if they don't have a traction or the tear, and then consider treatments for those who have lattice with holes or progression of subretinal fluid, poor access to care, which falls to the category that I just talked, poor vision in the fellow eye. So this is a higher stake decision, so we want to protect the eye that is left, and then other eye had RD or other sorts of pathologies. So we talked about the retina tears, different types of retina tears. Let's talk about retina detachments also, although many of them are not purely peripheral, so they extend eventually to posterior pole, but overall they are discussed with the peripheral lesions. So rhegmatogenous retina detachments are what we discussed. That there is a retina defect and or tear. Fluid passes through. Tractional retina detachment. This is a sickle cell retinopathy patient that had the vascular occlusion and progressed to tractional detachment. We see that very commonly in diabetic patients, right? So that's sort of typical tractional retina detachment cases. And also, and of course, exudative retina detachments. I'm going to just show you a couple of examples of each of these. So this is a 54-year-old patient with acute vision loss. So it's very obvious, this horseshoe tear in Opto's picture. There is a lot of, excuse me, so retina is detached, macula is off. So there is a lot of discussion now in the literature last few years about the OCT features of outer retinal corrugation, no corrugation, elongation of photoreceptor outer segments, and the importance or relevance of that to the visual prognosis. I'm not going to go through all those, but at least we know. So the patient got just a vitrectomy, gas tamponade, and retina is attached. Eventually. So this is a patient, a younger patient. Again, very typical. We see in our offices, younger patient, high stress or without stress, known stress, on a steroid or may not. But they come with subretinal fluid. So this is a type of exudative retina detachment that we see more commonly, of course, CSCR. So he has a very typical fluorescein angiography feature of expansile dot. But then I followed him, and really subretinal fluid is not going away. He's very nervous. He's very anxious to get his vision back. And then I did PDT for him, photodynamic therapy, and vision improved. Vision was 20/20, it still stayed 20/20, but better quality, he is happy. So then this is a more severe and extreme form of exudative retina detachment. 59-year-old monocular, going to get a corneal graft because cornea is bad, glaucoma implant because pressure is bad, and I'm just peripherally involved to do vitrectomy and come out because I'm going to just clean the vitreous for glaucoma tube. But now he's my patient because has a hypotony and exudative retina detachment, killing the patient, or the eye, huge exudative detachments, choroidal effusions. Fill the eye, I fill the eye with Helon, goes home, 2 days good, comes back again with hypotony and worse choroidal detachment. But eventually, I went, we went and removed the tube, filled the eye with oil, drained this choroidal hemorrhage and effusion, and he's better now for last few years. Again, so this is exudative retina detachment. There is no tear, there's no hole. This is just exudation or accumulation of fluid out in under the retina. And this was one of the extreme examples. So this is again, now let's go for tractional detachments, milder forms. So before pregnancy was fine, is diabetic, but then during pregnancy, PDR progressed like crazy and caused TRD, progress into macula. So she underwent surgery and then she's fine. This is more extreme form of tractional retina detachment, has already lost left eye from TRD for a few years. Now right eye, he was dependent on macula is detaching, and then he comes to us. After multiple surgeries and cataract surgery I did, removed the cataract, fixed the retina, but I didn't place a lens. I went back and put Yamani lens and removed the oil. Now he's also 24 division, doing fine. So this was an overview of retina detachment tears, other similar peripheral pathologies. Let's look at these pigmented and mass lesions in the periphery. So nevus, again, very common. we all see on daily basis in our practice, 5 to 10% of adult population, and in some stats say that in Caucasians, white people, is up to 30%. So 1 out of 3 or 1 out of 3 our patients could have choroidal nevus. Posterior segment nevus are common, as well as peripheral pigmented lesions. So these are the benign features. Probably if we see these, we don't need to jump into conclusion and refer patient. We can just watch the patient. Flat, meaning less than 1 millimeter thickness. We can look at these in mid-peripheral and sometimes even peripheral lesions with the OCT. Even if we don't have a B-scan ultrasound. Excuse me. So I have time. So overlying drusen just shows the chronicity of the nevus, and is a benign feature for this pigmented lesion. Absence of subretinal fluid. Of course, if there is a subretinal fluid, this is probably showing that this is a rapidly progressing mass, and could be a malignant choroidal melanoma. And of course, no growth, right? So we have followed patient, was in our practice. Now we took over, took another optos picture, exact same size. So this is probably just fine. We can just follow up the patient on yearly basis. So bad feature thickness, we talked about 1 to 2 millimeter borderline, may or may not be melanoma, but about 3 millimeter thickness is usually, this is a malignant tumor. Increasing size, orange pigment, this just shows the rapid stimulation of overlying RP that produces orange pigment. So these are features of rapid growth. And then lastly, subretinal fluid we talked about. Cherpi is also a common pigmented lesion we see in retinal periphery. Unlike nevus, these are usually jet black, not brownish, darkish color, deeper in the choroid. These are at RP level, jet black with sharp margins. Again, excuse me. Unlike choroidal nevi that has more indistinct borders, Cherpis have sharp borders. They can have halos around them. They have lacunae with loss of pigmentation in between. And these are also, of course, they need to be monitored, but the chance of progression to a malignant lesion is almost 0 for them, unless, so there's a type of Cherpi that are grouped, a couple of them, next to each other, almost like a bear track. That's why they call bear track sign. They can have, as part of Grodnicko syndrome, they can have GI tumors. And so, and we have had these patients. I've had these patients who came, just had Cherpi being followed, and then I saw, but then looked at the pattern and sent patient to GI doctors. Endoscopy was done, and they had adenoma, not malignant tumor, but adenoma, polyps in their intestine. So, and then lastly, the most feared, tumor in the retina or in the eye, choroidal melanoma. Then, of course, that's a different category of disease. If you find choroidal melanoma, or if it is diagnosed, what the treatment follow-up and treatment options is a whole different story and presentation. But I think what is relevant, for this afternoon's topic is that if we have a patient with choroidal nevus, they all need once a year or every other year retina examination, dilated retina examination. So when a patient comes to me for age-related macular degeneration, I'm following them, giving injections here and there. However, once a year, I dilate them for sure. I don't want to miss the chance of being able to detect their choroidal melanoma if it's happening. And it hasn't happened to me. I haven't found any choroidal melanoma this way, but I'm sure I'm going to find at some point. So again, we don't want to miss that chance. If a patient comes to us and eye is dilated, we better look at the periphery. Maybe there is a nevus, maybe there is a nevus that is growing and it's going to be bad down the road. So, and then for those who are older than 60, yearly dilated eye examination. And then high-risk group, of course, light-colored eyes, fair skin, history of ocular melanoma in family, and then certain genetic predispositions. Suspicious lesion, suboptimal examination, and not a good view. Of course, they need to be more carefully looked at. So this is also a good table. Again, I teach my residents, and there's very often questions about this. How you differentiate HRP from choroidal melanoma? Of course, we talked about these, the differentiating features, border, color, growth, and halo, and whatnot. And then lastly, looking at inflammatory lesions that present mostly in the periphery. So this is a 29-year-old patient presented with flickering light in the left eye. In the note, they say that there was no AC cells. Retinal vascular sheathing was, There was noted to have AC cells, vascular sheathing, retina hemorrhage, and some white-centered hemorrhages concerned for rot spots. Still, he was diagnosed with optic neuritis and sent to ER for IV steroid, thinking that this is optic neuritis, part of MS, so let's give him steroids. MRI showed non-specific findings, lumbar puncture, non-specific normal. Still, patient received 5 doses of high-dose steroids, or 5 days of high-dose steroid. Patient comes back, it's day 7, a lot of pain, vision is going down, and this is the retina. So this is a medical legal case in brewing already. So these are the cases in the periphery. There was something, even though they saw cells, but probably they didn't look carefully. And this is an ARN. It was an ARN in the making. One eye was good. The other eye now is with these patches of retinal whitening. So day 7, when he came to us, intravitreal ganciclovir foscarnet, we gave to him twice a week. Our oral antiviral ACTAP PCR showed HSV type 2, which is more aggressive type of herpes, one of the most aggressive types of herpes viruses in terms of ARN. And then vision continued to worsen. Retina gets better. Vitreous cells are better. Retinitis is probably looking better. I'm happy. However, it comes back with retina detachment, and this is very common with these, extensive, aggressive ARNs, right? So he received even high-dose Solu-Medrol before antivirals. So received vitrectomy, retinectomy, silicone oil, lensectomy for the patient. Still, vision, that was day 1 foot count finger, but vision really didn't improve much with more follow-ups, and this is really a disaster. Early diagnosis and aggressive treatment with systemic and intravitreal antivirals are imperative for preserving vision and preventing second eye involvement and disasters like this happening. Systemic and preocular and intravitreal steroids should be avoided, and long-term follow-ups are needed to detect and treat reactivation and late retina detachments. So this patient detached acutely, but very often, or not very often, but they can detach lately. And then other types of viral retinitis, I'm not going to go through those, like CMV retinitis. These are usually sick patients. We may not see them in our daily clinic, just community clinics. These are, post chemotherapy or during chemotherapy, immunosuppressed. However, they may present at some point to us for a benign red eye or something, and then they have retina whitening, a little bit of hemorrhage in mid-periphery or periphery, and they also need definitely appropriate treatment for eye to be saved. So this patient received ganciclovir twice weekly. So CMV retinitis is not as progressive as fulminant, as crazy as ARN, especially with steroid injection like the previous case. So these are usually more indolent, is slowly progressing, got treatment, and then the eye, end up well. All right, so I'm almost done. I'm gonna just show you a few slides, recap of what we talked. So these are benign lookalikes. So this is all a recap. We all know this, but again, better to review. Paving stone degeneration, there's no risk. So you really don't need to refer the patient. So you just, even if they are worried about, seeing the picture on your monitor, just reassurance and, sending them home. Chirpy, these are benign, but they better to be monitored, and choroidal nevus benign until they become malignant. And this doesn't happen very often, but they can happen, so we need to monitor them as we talked, every 1 or 2 years, or plus 60 individuals every year. So these definitely need more monitoring or closely monitoring. Lattice degeneration without symptoms. Of course, symptoms, they need to be treated, but without symptoms, monitor closely, warn patient, give warning signs to the patient, and of course, asymptomatic atrophic holes, they don't need to be treated, but they need to be followed more closely with good handout, good explanation of the symptoms of worsening. And then these are the red lights. So again, we saw the examples, we already know that. Symptoms, symptomatic horseshoe tear, subclinical RD, vitreous hemorrhage, so with obscured periphery, and with unknown cause, right? So if a patient comes with retinal, with TRD or diabetic patient, a little bit of vitreous hemorrhage worsening, probably we know what the source is. But if we don't know the source of this little hemorrhage in vitreous, definitely they need to be seen and looked carefully with good depression. And of course, mass lesions. So then let's go back to the exciting topic of optos, ultra-widefield imaging or examination. Do we need to examine them? Do we need to depress patients, or we can rely on optos? So optos, we all have it. We love it. It's very helpful in our day-to-day job, and it's excellent for documentation. Shows 200 degrees of the periphery. So patients love it, we love it. However, it has its own limitations, right? So we know that superior retina we cannot see, inferior retina we cannot see, eyelashes are very prominent, and it has definitely its own blind spot. So this is just almost like a clinical pearl, or a quote that says use ultra-widefield imaging as a map, not your destination. So just helping you follow the patients. And the gold standard is indirect ophthalmoscopy. We all need to hone our techniques for a good depressed examination without torturing or minimally torturing patients. That gives us good dynamic three-dimensional view instead of a two-dimensional view that we can get with optos. And when we should do it, if patient comes with floaters, with flashes. There is a vitreous hemorrhage, we talked about that. And asymptomatic patients who are myopic, has some sort of risk factors. So this is a patient, this is when I was in Houston, this with my cell phone I took this picture. So this is a patient I'm seeing in emergency room, looking at the optic nerve, that looks good. And then looking at the periphery, my friend texts me. So the way I do, I take a video as I look, and then I take screenshots. So the moment that pathology is seen, my friend is texting me. Anyway, so I have to. So anyway, so the screenshot is taken from there. But then in the periphery, he has an RD. So he has an RD. So this is a method that we published at that time with Austin and one of my other friend. We published, and this is online available with video, teaching of how to take just a retina picture. Probably in our offices we don't need this, but then it's good technique to have that and know to. It's a few-minute video. We teach how to take pictures with just your cell phone and a 20 or 28 diopters. And you'll be surprised how many peripheral lesions you can see. So over time, so, horseshoe tears, atrophic holes, operculated holes, I took pictures. So, and this is the last slide. Let's review one last time. 5 peripheral red flags. So Schaefer sign, we didn't talk about this, but again, brings up the concept of PVD and seeing pigments in the retina periphery. If there is a PVD, acute PVD, and if you are confident, periphery is totally fine, probably okay to watch them. But then if there is a suboptimal examination, they need to be referred. Overnight, of course not. In the next couple of days, they need to be looked at. Symptomatic horseshoe tear. So if we see a horseshoe tear and the patient have symptoms, subclinical, clinical RD, vitreous hemorrhage with unknown origin. We talked about all these, and then retina masses. So any retina mass that we are not confident about, their origin, their progression, they need to be looked at carefully. Thickness measurement and sometimes we need to do fluorescein angiography, indocyanine green angiography, and other features we didn't go through. All right, that was my presentation, I guess. Thank you so much. I'm happy to take questions.